So our next lecturer is a general and trauma surgeon. He is a senior consultant of trauma and general surgery at Hospital Sultana Amina in Johor, Malaysia. He is the chairman of the Trauma Surgery Society of Malaysia, an advisor of the Malaysian Association for the Care of Trauma or MASCOT. He is a member of IATSIC and an international faculty for DSTC. That's how I met him, and he is a member of the Academy of Medicine Malaysia of the College of Surgeons. So, ladies and gentlemen, it is my honor to introduce our lecturer, Dr. Rizal Imran Alwi, on incorporating trauma system into the Malaysian healthcare system. Dr. Rizal?
Thank you very much, Irene. It's been some time since I've been there, and I'd like to thank my friends from the Philippines to have me speak in this webinar. I have rather an affinity for the Philippines, which extends more than my name. Um, so this is Malaysia. We sit in the crotch of Southeast Asia, and we are smack in the middle of the crossroads between the Indian subcontinent and the Far East. We are a littoral country, which is what the Philippines is, and as well as Indonesia and Singapore. We have about 330,000 odd square kilometers that houses about 32 million people with a life expectancy of maybe about 75 years of age. As an overview to the Malaysian health system, the Malaysian health system is somewhat dichotomous. It has a very large public and an equally large private sector, which is perhaps not divided that equally in sense of revenue and responsibilities, with different funding and different systems running it. It can be a bit daunting to see, even for me, to see how money is being channeled to serve what. But in this diagram, I just wanted to emphasize that 82% of the hospital admissions are into the public sector, yet it's only 18% in the private sector. But where the outpatient visits are concerned, the private sector actually has the bulk of the patients. This includes general practitioners who are out there on their own, and includes private hospitals, private centers, and other things. Although the 35% of the outpatient who comes to the public sector may also come through the multitude of clinics that is run by the Malaysian Ministry of Health. It becomes rather confusing to see where money comes from, but in general, the public sector is being funded by government, and a small portion of it also comes from some government-linked insurance and social security. From the private sector, it's mainly out of pocket, and as well as private insurance. Malaysia always prides itself on accessibility of healthcare. We inherited a system from our colonial masters of the past, which were the British, in which the system more or less resembles what the NHS system is. So if we look at the distribution of healthcare facilities in Malaysia, whether it be government or private, we can see that there is almost no place in the country in which a patient cannot access healthcare, whether it be primary all the way to the tertiary levels. So the Ministry of Health runs more or less 144 hospitals and special institutions. These special institutions covers many disciplines such as oncology, uh, mental institutions, as well as rehabilitation hospitals. We are very heavy on the clinics because the thrust of delivering healthcare in Malaysia is to provide primary healthcare um, first and develop hospital care in tandem with the numbers of clinics that can serve the general public. Yearly, as for 2020, the Ministry of Health is allocated 30 billion ringgit, which is about in the range of maybe 8 billion US dollars to run the system, although usually the system runs at deficit on each year, so it would be in excess of 30.6 billion ringgit. If we see the trends, trauma is within the top 10 causes of hospitalizations in Ministry of Health hospitals in 2019. Now, this hasn't changed very much for the last maybe 10 to 15 years. We have always been top 10. And in 2019, we were the 6th on board. And it's also within the 10th causes of death in Ministry of Health hospitals. In 2019, that was we were number 8 on the list. As for the levels of care for trauma itself, trauma is catered by many institutions and many facilities throughout the country, starting from health clinics, hospitals without specialist services, to hospitals with specialist services, to tertiary or state hospitals, and also special institutions where they pertain, such as the rehab hospital. We'll see this a bit later, how it ties into levels of care within trauma. The evolution of specialistic services in the Ministry of Health in Malaysia actually started way long time ago. We have, as a country, a 5-year plan, which we call Malaysia Plan. And the specialistic services were first planned way back in on the 3rd Malaysia Plan. Every Malaysia Plan encompasses 5 years of planning and development of certain sectors. The 3rd Malaysia Plan was in 1976, and we are now currently on the 11th Malaysia Plan. So what started in 1976 as 3 levels of care and one concept, which is basic specialties, some additional specialties, and hyper specialties. I really don't know what that means, because back then I was about 5-6 years old. So I really don't know what they meant by hyper specialties, but that was what it was known back then. And there was some concept of regionalization of services that were incepted and planned way back in the 70s. And throughout the every 5-year periods, it has evolved into this, which is the last of during the last 10th Malaysia Plan, which was 14 state hospitals, and these state hospitals would have 20 specialties and 25 subspecialties, with 27 minor specialist hospitals, with 10 resident specialty services, 11 medical institutions with specific specialties, and so on and so on. So it is clear that the levels of care gets more and more defined as we go along through our history of Malaysia. So at the current moment, what we have now are the 145 hospitals with a capacity of about 41,389 beds. And these facilities consist of 14 state hospitals, 45 hospitals with specialists, 75 hospitals without specialists, and 10 special medical institutions. And if you see that in itself, it sort of resembles levels of care. So the plan for the 11th Malaysia, the proposal of the 11th Malaysia plan is that the strategic framework for Ministry of Health Hospital will be categorized into four major categories, which is the state hospitals, hospitals with specialists, hospitals without specialists, and the special medical institutions. Bear in mind that the care that starts off way down at grassroots levels is at the level of clinics, the health clinics, and the health clinics tie into the hospital care in sense of referrals. So there is a system. So if we look at the American College of Surgeons levels of care, which is defined, and every level of care is defined, we find that what system that we have evolved into, the levels of care resembles other levels of care, which one of them is described by the American College of Surgeons. And if we remember that the tenets of trauma care is that we try and match the expertise and the resources of treatment and management of the patient to the needs of the patient, which depends on the injuries that the patients have. So the different levels of care would serve the different levels of injuries. And that is replicated in the recommendations by the World Health Organization for provision of trauma care, which is levels of care, again, with different levels of care. So if we do have different levels of care, and the system has evolved into providing levels of care, then what would be the problem with Malaysia? Well, actually, to think of systems, there wouldn't be any problems. But unfortunately, we aren't doing so well. So looking back, if we look at a decade ago, we can see that trauma is number 3 in contribution to the causes of hospitalization. And this was data from 2011. And it was number 7 in contributing to the causes of death in Ministry of Health hospitals. Now, did we go better? Did we do better in 10 years? Perhaps, as if you realize, we went from number 8 to number 7 as the cause of death, but it's generally there. It's generally unchanged. If we had a very good system to cater for injuries using the existing system that had evolved over the long period of the 1970s till it is now, why do we still have injury as one of the 10 principal causes of death? And we would expect that in 10 years, this would be gone, or certainly way down on the list. Now, I can't really go back beyond 2011 because data is scarce and disorganized. But I do suppose that if we were to look back 20 years ago, there would be an appreciable change to what we have, what we had back then to what we have today. But would that be any reason not to improve? I don't think so, because if we look at our surgical post-operative mortality rate, and this was the rate that we looked into the last year, and it was reported by my superior, who is the head of general surgery. We see that a large proportion of deaths were emergency deaths, and electives come at a very low rate. Trauma was third in contribution to the deaths in the perioperative mortality review. So the question is that if the system is used, why isn't it working? One of the biggest question is that one of the biggest question that we were thinking about is that there has to be a paradigm shift in the mentality and the mindset of what is electives and what is trauma and acutes. A good system and organization um, works well, provided that it doesn't evolve into a bureaucracy. And if it does evolve into a bureaucracy, it doesn't work well for trauma and acutes. We cannot have a transfer time of 8 hours over a distance of 30 kilometers, for instance, in Malaysia, where everything is accessible by land as well as by air. But that happens on a daily basis. If we were to take a system that works, but we change it into not only an administrative bureaucracy, but a bureaucracy in an art form, um, it will do more harm than good. And I think that that paradigm shift in the mindset has still not been able to be penetrated even till today in our practice. So what we sought out to do was two things, because we thought that to improve, we need to engage and we need to educate. And who do we engage and who do we educate is another question. And how would the approach be? Would it be a top-down approach, or would it be an enforcement or voluntary approach? Should it be that levels of care is designated or by accreditation, since we do have levels of care? And should it be local and regional and duplicated elsewhere? A top-down approach, at the end of the day, we tried everything. We tried a top-down approach, we did a down-to-top approach, each with its own strengths and weaknesses. As far back as 2007, the Malaysian government had issued out grants to senior consultants to undergo courses. For instance, the STC back 15 years ago, there were grants to get senior consultants, senior surgeons, surgical consultants to take up the STC, for instance, in countries, neighboring countries. I remember that time it was our friends down in Singapore that provided a lot of support for us. This approach was in the hopes that the more senior the more senior they were, the more they could affect change in the management of trauma patients. But this was not true. This was not true, and it's because that very few senior consultants and senior personnel and senior staff actually engage in the early treatment or even in the active treatment of trauma patients. So although they might know and they might be into the concept of trauma care, they might not be able to affect much change in the mindset of the more junior staff and personnel, because they are simply not there when the trauma patients come in. As for enforcement, whether we need to force people to follow certain things, to follow regulations, to follow SOPs, standard operating procedures or whatnot, I think it's a bit of both, because even if we were to force staff to do and to adhere to some certain things within the work process of managing trauma patients, it may not still be done well because it's not done voluntarily. As for designations or accreditations, we had problems with the fact that the Malaysian system is a very fluid system. The services that are provided by, let's say, a specialist hospital today might not be there 3 months in the future, might not be there next year, because people move, things move, and things change. So the easiest way is to actually keep track of the changes and for the system to designate the centers into the levels of care. And at the end of the day, I think that's what we did, and that's what works better for us. As local and regional examples, yes, it's true. We have started off with certain regions, and we hope that other regions can replicate what has been done on a small scale. Malaysia is a very diverse and heterogeneous country when it comes to geography, political conditions, and lots of other things. So in considering the local conditions in a more detailed manner would be better than a machine gun approach to trying to try to fit a square peg in a round hole. So what we did in engagement is that we tried to create policies and programs, both at the central Ministry of Health levels, all the way to the state levels, and to the hospitals that are involved. So each levels would have their own committees and subcommittees and so on, and to discuss problems that they face at each level of care. Now, bear in mind that their problems would be unique to their locality, and this is just to be respected, because if you have 330,000 square kilometers to cover, I don't think that you can fit a single cookie cutter to everyone. Engagement also involves identification of stakeholders to see who are the people and the players that would benefit or would not benefit from such policies and programs, and explain to them and try to get them on your side to work as a team. It takes a lot of effort to do this, and the stakeholders, the identification of stakeholders sometimes requires a lot of strategic thinking, because they may not be people who are clinicians. They may not even be people from within the within the medical services or the medical profession. They may be lawmakers. They may be people from finance who would help in getting programs off the ground. They may be people who are career bureaucrats, for instance, who may come in handy. Um, and we started some local and regional protocols, and these were very much tailored for the locality. And I would like to emphasize again that you can't force a certain standard on a locality because of the inherent differences that they have. We also engage the training program groups, those people who train not only the surgeons but also the medical students, the postgraduate program directors and so on, to see whether things can be changed in the way that we train surgeons, for instance. Because in Malaysia, surgeons are trained very traditionally. The emergency physicians made their debut in Malaysia as the youngest specialty, perhaps in the early 2000s. Trauma surgery was incepted as a subspecialty in the Ministry of Health in 2008. The emergency physicians predate the trauma surgeons by at least nearly a decade. The problem with having surgeons and surgical training, postgraduate training done traditionally, is that trauma and acute care surgery has never been an independent part of the curriculum. It has never been emphasized, and yet the results show now by looking at the statistics on how we are trained. Meanwhile, the emergency physicians are more in tune towards trauma care, at least. I'm not sure about acute care surgery, but certainly in trauma care, they understand concepts easier and they are more in tune towards it. So where education is concerned, ATLS, for instance, was incepted way back in 2009 in Malaysia. I think we had the first inaugural in 2009. We began to send people off for the STC. We had our own homegrown courses, and we did roadshows for the sole purpose of getting people to speak the same language about trauma, so that we can share ideas better. We can be at the same level of thinking when it comes to the management and treatment of trauma patients. We have also engaged the committee that looks into the national postgraduate curriculum. There is a policy out in the making, but since COVID-19, everything has come to a stall, including the first inaugural DSTC in Malaysia. I'm sure Almin would know about that. The plan was that we would have had a course, the first course done last year, but unfortunately the pandemic intervened and everything is on hold. So the national postgraduate curriculum, um, this body looks into the policy that will create a national postgraduate curriculum. And we wanted to have our voice heard that trauma and acute care surgery should be incorporated into the postgraduate curriculum of surgery, because the emergency physicians have it in their curriculum. As for advanced training for specialists and surgeons, yes, we've had made headways slowly, but not as fast as we want to. I'm sure the Philippines have a lot of trained trauma surgeons. I'm aware that they have about 70, more than 70 trained trauma surgeons, while in Malaysia we have exactly 7, right? So that's how we are. And then not to forget our colleagues and partners in managing patients, the nurses. I think they should be given emphasis as well on the trainings that we plan for them. So where are we now? So from the plan that we hatched about half a decade ago, we have managed to get the southern part and the middle part of the country's staff with dedicated trauma surgeons and trauma surgical services. The north is still in the making, and we hope to have regionalized service in the east of the country, the east of the country, in 2 regions of Sarawak as well as 2 regions in Sabah for the next maybe 20 years to come. But that's quite far ahead as far as we are concerned with. We will try to do better and better as the years go by, I suppose, but there are many challenges that we face in Malaysia in creating these systems, even though we do already have an inherent system, we just don't know how to use it. So before I go, I'd like to remind everyone that the International Surgical Week is planning a virtual surgical week from 30th of August to the 3rd of September. We hope it materializes because since the pandemic happened, everything has gone to a standstill, and our plans to have ISW in Kuala Lumpur has stalled. So we will see what goes and how it goes. And again, thank you very much to my friends in the Philippines for having me for this talk, and thank you very much.